I was asked to talk about psychological therapies, and there's an article in The Lancet I wrote with Manuel Peters and Juliana Owumeri talking about a view from the hills, taking a slightly longer-term view about where these therapies have got to, and really having an idea about how research turns into clinical interventions and how important that is to move just from research basis, but to actually try and help people in the distress of psychosis. As Graham Thornycroft has so wonderfully discussed, these problems are extremely unpleasant to have, and it's not to be underestimated, the problems that it causes. I wanted just to flag up the Understanding Psychosis and Schizophrenia book that came out last year, 2 years ago, 2016, which had a lot of service user content talking about people's experiences and what they wanted us as professionals to do. And I want to focus my talk on the importance of positive symptoms, which are only part of the picture of psychosis, but are often the most distressing part for the people who experience them, and the least understood part from their own point of view. And how that's led to particular interventions, and I'm only going to talk about the CBT, the cognitive behavioural therapy, and the family intervention therapy for psychosis, because those are the ones that I'm expert in, those are the ones that are recommended treatments, and those are the ones where I've been doing the research. And finally, just to talk about some of the new interventions for very specific and targeted problems, which I think will help to improve the outcomes more clearly. Interventions on worry, on sleep and voices, and on reasoning, which I'll talk about, and also interventions for carers and the families themselves, who are often rather left behind in this. This is a picture by David Marsh, a detail of a painting entitled Imagination, from Schizophrenic Artist Paintings Out of This World. This is a quote from someone in England who later on became a clinical psychologist, but when he was 18, this happened to him. He was sectioned in a psychiatric ward. And when he first went for training to be a clinical psychologist, he did not mention any of this, did not mention his previous mental health history, but he has since, as Graham was talking about, very bravely come out about this, is now a clinician himself, and is very vocal on the kinds of issues that you face. And as he says, when he was sectioned on a psychiatric ward, he felt that he'd become a social outcast. And Robin Murray headed the Schizophrenia Commission in 2012, calling it the abandoned illness. As we know, it's not unprevalent. There's quite a lot of people are affected by these diagnoses, particularly if you take broad definition of them. It emerges, as we know, between late adolescence and early adulthood. And it's got all these... I don't know if I've got the pointer. Have I got the pointer? Oh, no, that's not the pointer. Is that the pointer? No. Anyway, it's got all these problems with unemployment, social discrimination, as has been talked about. Is there a pointer on it? That's going backwards, isn't it?
Pointer.
No, the pointer. Okay. Oh, that. Oh, okay. Thank you. And the high rates of mortality at an earlier age. This is Sue Morgan's Mind Furnace. This is from from our local hospital in the UK in South London, the Bethlem Royal Hospital, which has now got an archive of some of the art done by previous inmates. We also know that, particularly in the early years, substance abuse and deliberate self-harm raise rates, and there are very high societal costs of care. And as I said, although the first line of treatment is medication, many people do not like to take this. It has a lot of side effects, and it doesn't work for everybody. And so we have been particularly concerned with the up to 40% of people who remained very distressed, even on medication and without it, by their symptomatology and by what's happening to them. So this talk is focusing on them. So the early cognitive models of psychosis made a very particular set of ideas about the importance of appraisals, because being psychologists, we can do something about how you make sense of the world, how you try and take meaning from the huge array of stimuli that you come across. And we posited that this leads to recurrence and persistence of these positive symptoms, and that there's a whole range of cognitive, social and emotional processes which contribute to them. This is now quite an old article, 2001, 2007, 2006, and as we've heard today with Robin Murray, there's obviously the vulnerabilities, there's the dopamine issue, there's the genes, and then on top of that, you're going to get triggered perhaps by something and it's your reaction to the trigger, it's the emotional changes, it's the spike in dopamine, it's the upset that causes. And it's then what you do with it, it's then how you think about it and what you decide. And when you start feeling that what's happening to you is not in your internal stimuli, but it's coming probably from outside, that someone is threatening you, is after you, there's something you worry about, that's when these experiences are turning into positive symptoms. And this is the circuit that we've been very interested to try and change. So we've heard there's a bit of a disadvantage coming second to last in a conference. We've done all this, haven't we? There's been evidence on the continuum hypothesis, and our group particularly has been interested in the importance of affect. The non-affective psychoses are absolutely brimming with affect. It's just there. And it's a very helpful thing to know about, because that's often the way in, and a much less stigmatizing way to talk about someone's problems with anxiety or sleep than to talk about their delusions initially. And then a lot of research about the social adversity, and we've heard about this, and the trauma and bullying and life events which are contributing to the problems that people have. So just quickly, the continuum hypothesis is now very well evidenced, and subclinical and clinical psychotic thoughts and experiences are observable in the general population, are not just kept for people who we thought were different from us. And they're very interestingly associated with the same risk factors as the clinical disorder, and that's the ideological continuity. And up to 40% of the population have paranoid ideas about all sorts of things, and these are associated with the same things as in clinical populations: anxiety, perceptual anomalies, worry, and what's called cognitive inflexibility, which I'll talk about a bit later. This is Daniel Freeman's work. We've also, there's a whole line of work that he's taken forward about how sleep disorders, if you lack sleep, if you've had insomnia, that makes you much more liable to have delusions and hallucinations. But these symptoms alone are not enough to move you across the threshold. This is a paper that Paul Bemington wrote, the distribution of paranoia scores across the total population, the general population, with 8,000 people. Paul tells me this is one of the most exciting graphs that he's ever made, and as my husband, you do have to worry just a little bit about his excitements, but there we go. And as you can see, what it shows in a very perfect curve, beautiful curve, I do agree, is that a few people have lots and lots of problems, and many people have a few problems, and that's how it goes across not just the clinical population. And we were hearing about Insel a little bit earlier today. Even he thinks that there is a dimensional aspect to the classification of patients, and that there's many etiological pathways leading to the final mixed bag of behavioural signs and symptoms we label schizophrenia. So we were very interested in affect, and when you start looking at it clinically, when you do use clinical measures of the kind of problems that people have when you stop, you don't just look at their hallucinations and delusions, you find that there's all sorts of other things as well. There's high levels of depression, there's at least 30% fit the criteria for previous trauma, panic disorder, obsessional compulsive disorder, and really about half of them have comorbid personality disorder, and with that combination you have very high bed use and very high societal costs. And this is really quite well evidenced now. There's a range of cognitive biases that relate to it, and positive symptoms are often related to negative schemas, how you think about yourself, is going to make you more worried about the world and other people, and it's also related to what happens to you in a family. I'll come back to that. It's also the case that we've got really good evidence now that things like depression can contribute to the later development of delusions, particularly if you have pre-existing perceptual anomalies, and cognitive and emotional related processes are involved in delusional ideation. The group in Gomez have done the very detailed work with time sampling, where you wear something on your wrist and it pings randomly about 10 times a day. It's quite irritating when you do this, but particularly if you're rushing about trying to get other things done. But when you look very closely at the fluctuations in your activity levels and what you're thinking about and your positive symptoms, it's very, very clear that affect and symptoms are very closely linked. And we showed in a paper that there's a mediation effect for negative cognitions, and it was a very interesting paper, I thought, by Hafner, talking about the starting point, the trajectory of depression and psychosis having the same initial starts and indistinguishable until the emergence of psychosis symptoms. So these pathways, they're not just separate, they're linked to a lot of affect. We did a paper with Mawaha, the mood dysregulation. We just asked one question that came from the National Survey. Do you have a lot of sudden mood changes? And that, answering yes to that question, increased the risk. And also, if at a baseline you had mood instability, significantly predicted new ideation and auditory hallucinations 18 months later. It's a serious risk factor. We were interested in appraisals, as I said, these appraisals, and there's been quite a lot of work done in physical illnesses. What happens to you if you get heart problems or cancer? And people like John Wyman talk about the fact that your illness appraisals, how you understand the illness and how you react to it, is the key predictor of outcome, i.e. whether you'll take treatment, whether you'll change your lifestyle, whether you'll do anything about it. And so we decided to have a look at these in psychosis, and of course you get very similar processes going on, that if you have a negative illness appraisal in psychosis, you're much more likely to be distressed. If you feel that it's the end of your world, obviously you're going to feel much worse about it. And anger is a key mediator of violence in psychosis, so how you feel about your delusions and who's causing them will often cause you to act on that. And it's also part of why you have safety behaviours. You never want to test out why you're feeling so threatened. So even if the threat has removed itself or it's not relevant anymore, you still won't risk going out because you're worrying about things. Reasoning biases. We all have these. You all have them, I have them, it's very common. And i.e. we hold ideas with great conviction that really don't have any evidence. Things like ghosts and telepathy and astrology, many people read those things. I'm rather embarrassed about this Wired magazine quote, but I thought initially Wired magazine was a bit of a joke, but it's still there, isn't it? And, people believing in aliens, it's very common. And the issue really is that once you hold a view with conviction, you have this confirmatory bias and you don't test alternatives. And particularly with the social media, we all live in a bubble of just talking to our friends who agree with us, reading the newspapers, the media that agrees with us, watching Fox News and not anything else, and thinking everybody else is lying. And we just continue that. And so this is nothing to do with just having delusion. We're all jolly good at it. And additionally, if you have psychosis, what you may tend to do as well is you're very quick to make a decision. You're very quick to look at the evidence, say, right, this is what's happening. I know you're out to get me. I know that part of the audience over there really doesn't like the look of me, and that's really quite worrying. So you're very quick to do this. This is a task from Moritz and Woodward. Now, the requirement is, what do you think this is? I'm going to give you some more information. You've got to decide when you think you know what it is. Anybody convinced? Oh, there we are. So it's an elephant. Okay, now I won't ask, but if you thought you knew what it was in the first 1 or 2 slides, not so good. And people with psychosis have this lack of this jumping to conclusion, this JTC, and lack of belief flexibility, and are very quick to just use a very small amount of evidence and decide, feel threatened very quickly, and don't sort of check things out in quite the same way. And at least half people with delusional beliefs have this, and it's linked to how convinced you are. And very more recently we found it's related to poor working memory particularly, but not your overall IQ. And as you know, there's lots of other cognitive processes that are relevant to positive symptoms. Talking about salience, as Robin Murray was this morning, there's subtle differences in affect and cognition, and how stress can increase the salience of stimuli through a dopamine spurt. And there's also ideas about people with psychosis having self-monitoring problems and not recognising their own thoughts as they're thinking that their own thoughts are more external. There's also poor use of contextual information, your ability to process what's going on and take out what's salient to you and what really matters rather than what you're worrying about. And there are, of course, working memory and attention problems that don't help any of this. And finally, as we've heard, there's been huge input from adversity. And I don't need to go into this in a lot of detail. We've had a lot of information about all this in urbanicity. James Kirkbride has talked about migration issues very interestingly and making that much clearer what's happening. Graham's talked about the perceived disadvantage and the problems that people have. We did a little bit of research, which links again to what Graham said, about the lack of a confidant and how many lonely days a week, even at first episode, people had. How quickly, with someone with psychosis, you just fall out of your social network. Everybody, you will have known someone at school, perhaps 2 or 3 people at school who now have psychosis, but you probably aren't in contact with them because once you get these problems, you don't stay friends with someone. There's also, from Marta de Fonte, we'd heard about the cannabis risk, particularly with high potency and earlier age of onset if you do that, and all the other things. Right. And there's also all the family work that I've done research with for a very long time, initially with Julian Leff, and finding out that intrusive and negative family environments relate to later relapse in psychosis, impede your recovery, particularly if your carers are not very tolerant of you, and this predicts very clearly how you'll feel about yourself and how difficult it is to get better again. And what we predicted was that particularly family intervention in psychosis needs to work through this affective route by calming down the aversive environment, by keeping people's ability, perhaps in Robin Murray's words, by normalising the dopamine environment and calming things down. And that's exactly what we've tried to do. Just to make a note, we started after a while to just ask the service users if they had a critical relative, which is one question, and it's as nearly as predictive as doing a 2.5-hour interview, so that's good. That's good. And we know about the trauma that's come through very clearly. High rates of traumatic events predict onset and associated with CSA and bullying, child sexual abuse and bullying. And I don't know if I've got time to talk about this. How are we doing? How am I doing? Okay. And one of the things we've done recently, particularly about bullying, with Gennaro Catoni, and this is one of my Italian connections because I have an Italian daughter-in-law who is called Giussi Moffa, and my son also is involved in this analysis, and Paul Babington and Gennaro. And what we were interested in doing was trying to use a large amount of data, big data, from National Survey, in using Bayesian analysis, directed acyclic graph analysis, to look at the probable pathways between an unpleasant event happening to you, probably before you had psychosis starting. Bullying is more likely to be like that if it's childhood bullying. And using this particular analysis to look at the pathway between bullying and what happens next. And what you find from that, this was National Survey data, so about 8,000 people in the sample, and what you do is you develop a probable, this is not easy stuff, you develop probable pathways which look most likely to be significantly linked. And so you get nodes and edges, and you can draw a pathway. Now, I don't have the drawing, but it's very complicated. You may be glad about that. But what you find is if you start off with bullying and hold that constant, the key issue is that it makes you worry. And then that is later leading to paranoid ideas. And that is a very key pathway. And we're also starting to look at sexual abuse and how it all links together. But you've got these effective routes towards more positive symptoms. And one of the issues is, how does this work? And we think it obviously affects your information and emotional processing, affects how easily upset you are, how threatened you feel, and how worried you are about how safe the world is if you've got these kind of problems. And particularly intrusive life events, for instance, are the most difficult things because you feel personally attacked by them. So there's all the work about harsh parenting from the Ausbach sample and Helen Fisher, and childhood adversity and adult psychosis. And there are some rather specific things about childhood rape with hallucinations. You do seem to get a pathway with CSA and depression and hallucinations, and more physical and emotional neglect with paranoia. That's Richard Bentl's work. So there is reasonably good evidence for the kind of cognitive models that we've been interested in because we were wanting to use these models to apply it clinically to try and help people talk through what they were experiencing, and particularly using the affect route. And what this has turned into, as I'm sure you all know, in the latest NICE guideline updates for schizophrenia and psychosis and schizophrenia, I chaired the 2009 and the 2014 guideline updates on this. And there's a very consistent, it's still recommending that CBT for psychosis at least improves symptoms, and the family intervention reduces relapse rates. So these remain recommended. And I was glad to see in the last guideline, we looked particularly at what helped carers. And there is evidence now that direct interventions for carers, because carers won't always come to a family meeting, and then they kind of lose out. They can't always see the point of it, and they're exhausted themselves, and you can see why it's quite difficult to set these up. And so talking to them directly themselves, this is also very helpful. And it's not just the UK that's got these support guidelines, also recommend these two interventions, amongst others. And CBT and FI are also recommended for children and young people. And we've done some detailed work looking at how much you need to have, that having more of it means you get a better outcome. So actually engaging people and keeping them in session, which is not, again, easy. Not everybody wants to talk about their problems. Some people just want their problems to go away and hope that it won't come back again. And so engaging them in treatment is particularly crucial. We've got evidence now from early intervention services in the UK, and of course Mirella Ruggieri's wonderful Get Up studies with her from 10 million catchment area in North Italy have shown very clearly that you can implement these interventions in a much wider context. And there was a bit of research showing that particularly early intervention in the UK was relating to whether you got these two evidence-based interventions, and that it was about availability. We've been able to show that after you have CBT for psychosis with Veena Kumari, that you can get neural changes, that it changes your brain fairly obviously, i.e. it changes the fact that in the scanner afterwards you're less likely to be so upset and react as much to angry and neutral faces. And this improvement in your reaction to sort of unpleasant things, there was a recent study by Mason showing that the brain connectivity from that was around 8 years later. So there's something about a more permanent change if people will engage with this. There's also evidence from the prodromal studies, although the transitional rates are really low, so you can't show it very easily. But CBT can be useful without medication, and Toni Morrison has done a lot of really quite controversial studies about using it without medication and showing this can be of help even if you refuse medication. And finally, there's new interventions, which, as I say, are getting to be much more specific. It's a bit like not just doing everything you can possibly think of, but trying to target what mechanisms you think are going to be crucial and see if that will help people improve faster. So Max Birchwood did a trial looking at command hallucinations and improved outcomes, reduced the distress and the likelihood that you'd act on them. Daniel Freeman has been discussed about Paul Beverton talked about this, the WIT trial and the insomnia trials. So he's looking at the moderator, he's looking at the anxiety from insomnia and from worry and dealing just with that, and that can also improve your paranoia. There's work from Mark Vanderberg talking about PTSD treatments, and people have been quite worried that you shouldn't talk about trauma directly to someone who's having psychosis symptoms because you would upset them too much, and he's showing that this is safe and efficacious and also helpful. Which is nice to know, because when I was working clinically, I used to have to, if you try to refer someone with psychosis for her trauma, the trauma clinic would say, no, we won't deal with them. They're too upset. And so I would end up listening to the trauma and dealing with it and hopefully getting them a bit better. It did work. And we've done some, I think this is, well, I would, wouldn't I? But I've done some very nice work with Suzanne Jolly, looking at children with psychotic-like experiences, which is not psychosis. But if you ask even very young children from about 8 to 14 about their experiences, if you ask them about it, there is a proportion of people who are having distressing psychotic-like experiences. And they're not so permanent as adults, they're more transitory. But they are coming to clinics and they're asking for help, and many clinicians don't necessarily know what to do about it. So we developed a manualised treatment, all very child-friendly with a lot of service user input, which has been shown to be acceptable and useful to people. And one of the key things I thought about this to improve their resilience was to get them to talk about it, because none of the children had really told anyone. Or if they had told their parents didn't know what to do about it. And so if you ask the parents, they say, oh no, they haven't got anything like that. And the children would say, yes, we have, but we don't know what to do about it, and we don't like to mention it. So asking very specific, non sort of upsetting questions about what's going on, and also dealing with it in a normal way. Yeah, oh, really? You're having these problems. You think that if nobody looks at you unless the wind changes, so you're always looking out the window. Nobody's going to be your friend unless the wind's changing, and that's going to change your behaviour as a small child and cause all sorts of problems later on. So I'm very keen on very, very early normal intervention and picking up these problems before they just get set. And then the most recent trial is the Avatar trial with Tom Craig and Philippa Garrity. Did a randomised trial comparing it to. This is the work with avatars, where you turn your distressing voice into an avatar, into an image on the screen, and the therapist helps the avatar become less unpleasant and distressing, and you work with someone to kind of normalise that as well. And what they found interesting was that supportive therapy is still jolly useful, I'm not entirely pleased to say, but avatar therapy was quicker, got you better faster at 12 weeks, but the other groups caught up. So it's not quite clear how that's going, but they're going to be doing a lot of moderation analyses to see what was changing when and what you could focus on to improve that. CBT for psychosis is still controversial. There's still a regular stream of papers saying, no, it doesn't work, it's all nonsense, isn't there, Robin? And it's just quite interesting why people are so worried about the CBT. We don't get that in the family work. People aren't saying the family work doesn't work, but there's a lot of. It's very interesting that it's been so attacked. But my view is, to date, there have been 12 meta-analyses, 50 randomised trials. Effect size are small to moderate. That's quite right, and they vary, and it depends how you do it and what outcomes you use. What we know so far is that it's better if all else has failed. It's better if it's formulation-based treatments, and it can make you kind of feel more in control of things. And particularly, we're interested just at the minute in targeting the mechanisms. And do you remember me talking about the reasoning biases, the elephant? There's a new trial that Philippa Garrity and our colleagues have just set up called the Slow-Mo trial, because we've developed an app, a phone app, to help people between sessions. And the idea is to be very, very focused on just slowing down your decision-making. So when you see a situation that looks worrying, You're asked not to just make a decision about what's going on, but to look for alternative information and slow down your thoughts and think again about what might be going on and see if it's as unpleasant as you think it might be. And one of the key things, I think, for that, it's an 8-week manualized treatment. One of the key things is that you talk about it. It's a computer-based intervention. You're talking about it with a therapist on the computer. You've got a phone app that can help you with your coping when you're out in the street. And the therapists mainly go out in the street with them for at least one session to test out and cement the new thinking. So when you're out in a crowd thinking, oh God, nobody likes me, it's all, I've got to hide in a shop, you can actually discuss this and deal with it in the moment. And that behavioural cementing seems particularly helpful for people with these very highly convinced delusions. But we'll see. It's only just started. I think the results will come out in 2019. And last but not at all least, caring for the carers, which I've always had a very strong strand of research that I've been interested in and tried to help with this. What we have found out more recently is there's a critical sort of cut-off. More than 10 hours a week care is stressful for any carer. So I don't know how many of you are carers for someone at the moment. 10 hour a week is not very much. And if you're the person who's, often carers are on their own, if you're the main person in charge, you are more likely to be stressed after 10 hours a week. There's a step change, it goes right up. And what happens is that while you've got a very helpful role to play in the outcome of psychosis, in reducing isolation, in helping deal with things, talking things through, helping medication, all sorts of things, getting services involved, it's often coming at a cost of your own stress, depression, your grief and your loss. And 90% of carers would like more support. Now, the problem is most of them do not want the kind of support that we want to give them. And so you get into a bit of an issue about how to help carers who some say, well, I'm too busy and I don't want that and I don't want to talk about it, just make him better, just sort it out. And so it's not as easy as you might hope to do this, but problem solving and information support does improve outcomes, and any way you can get that through and offer that to carers is extremely helpful. I've tended just to answer people's questions and be available and kind of be there to kind of help sort things out. Availability is a huge key thing for them. And there's cognitive models now of caregiving about how to really focus on this. And there's now quite a call really for self-direction and dissemination, allowing carers themselves to give something back and be part of that improvement. And many carers wish to do that, and there has been some successes in that. And one of the most recent things is, I never know what this stands for, massive online course, whatever the other is, available, which has just been set up at the Institute by Juliana Omomeri. And that's been amalgamating a website that we had before and is up to date, has got all sorts of people talking about it. I think probably both you, Graham, and Robin, and probably you, Marta, I don't know. There's lots of people on it. It runs twice a year. It's reached at least 37,000 people so far. And it's just a way of giving people the kind of answering the questions, talking to people, destigmatizing in that sense that these things happen, there are things you can do about it. And that's continuing. I'd like to finish with a quote from, this is an untitled poem by Wendy Baker, who came to one of our clinics, the Pickup Clinic, and talked about what it was like to try and make sense of things, untangling worries of things that might be, controlling and broadcasting all about me. The tills in the shops are a panic alarm, untangling worries which may cause me harm.